thank y'all for coming out. I really do appreciate it. I don't have any problem if somebody needs to get up, leave, wants to leave. Please, it's your night, and to come out on a school night like this, I can't be more appreciative. I'm going to tell you a little bit about some hormones and menopause. I will take questions, but at the end. So y'all just shout at me if I'm in the way or anything like that, or if you can't hear me, or if I mumbled or something like that. All right, Seth, I'm just going to do that for the next slide. All right, so I'm George Ibrahim, and my place is about 2 doors down, Biltmore Restorative Medicine and Aesthetics. And I've been doing this for about 14 years now, 13 years. I used to be a urologist, came down with multiple sclerosis. That made operating a little bit difficult. Well, bioidentical hormones were just coming out about that time, and urologists learned all about, the hormones, and men and women have the same hormones, just in different orders and priorities and amounts. And I thought, this would be something I think I can do. And I got into it. And as people started to feel better, middle-aged men and women, mostly women at that time, as they started to feel better, they wanted to look better. They cared about how they looked. So people started asking, who does this, who does that? And at that time, the plastic surgeons and the dermatologists were being real doctors. They weren't doing much of aesthetics. There weren't any med spas on every corner like they are today. And I said to myself, well, hell, if I can make a bladder out of a small bowel, I can damn sure learn how to inject Botox or dermal filler. And so we started doing that. And then things kept moving on, and something came up called sexual wellness medicine. And well, that's my anatomy. I mean, that's where I operated for 30-something years. And so I got into the sexual management part of things. And this talk tonight is not really going to get into that. But what we're talking about are ways to help men with better erectile function, and women with better, faster orgasmic capability. There's a lot of cool ways of doing that in the office that are painless, but it's not really part of today's talk. All right, Seth? What's this next one? So, big paradigm shift. This is how I look at it. Do our hormones go down because we get older? That's what people used to always think. I don't think like that. I think hormones go down, or we get older because our hormones go down. Not quite a quick story, but a good one. So I'm in med school. We're doing a hysterectomy on a 38-year-old girl, taking out her uterus and her ovaries. And I was told, put this estrogen patch on her when you get to the recovery room. So I wheel her to the recovery room, get back to the ER, do the second case. Second case comes out. We're going back to the recovery room with the second case, and my first case is sitting in there, and this woman is wailing. She's all over the bed, and I put my hand in my lab coat, and I went, and I'm holding the estrogen patch in my pocket. So I go in there and I slap the patch on her. Walk back out, go to do a third case. Third case over, coming back to the recovery room. First case is coming out. She's as serene as she could be. She had gone to bed as a 38-year-old, feeling like a 38-year-old, and then she woke up feeling like she was 70. Just like that. And it didn't hit me at the time. I didn't think, I was doing urology. It didn't cross my mind about anything, except that I had forgotten to put on her patch. When I got into hormonal medicine, that story came back to me, and I went, that's what happened to her. Abrupt, just removal of her ovaries, instant menopause, horrible feeling, and then the serenity of when she got her hormones back, and that really struck home. Next, please. So what's this big fear of hormones? Why don't you hear your OBGYN talking to you about it? Next slide. This is the biggest reason. So something called the Women's Health Initiative. They got 70,000 nurses. With what? Let's back up a little bit. The government pays for Medicare. And the government realized that menopause wasn't just a pain and a horror, feeling for everybody and their partners. It was deadly. It was costing the government a lot of money. Women that went through menopause had a lot more problems. Their death rate soared, and I'm going to show you why. And the government was paying for it because, by definition, all of these women were Medicare age. So they said, well, we got to do something. I mean, we know what's causing this. It's the loss of their hormones. Well, let's just give them back hormones. But we didn't have human hormones. So this whole study is based on the premise of a woman losing bioidentical human hormones that they replaced with nothing except things that have words and letters that look about the same but are completely different. It's the wrong estrogen. None of you are horses. Premarin, the largest selling drug in the history of the world. They didn't even take 10 minutes to figure out, what are we going to name this product? We just named it what it was. Pregnant mare urine. Premarin. Horse urine. That's what millions, if not billions, of doses were given out. And that's horrendous. Think about what happens if you put horse hormones in a human woman. Well, bad things happen. I'll show you what happened. The wrong progesterone. Progestin and progesterone have about 3 letters in common, and that's it. Progesterone is the biggest hormone you make during pregnancy. It's protecting the uterus, it's protecting the baby, it's protecting your breasts. Progestin is the morning after pill. Progesterone comes from the word pregnancy. That's its root. Progestin is an abortion pill. But they substituted that, and we're thinking that they were going to get the same results of what it's like to give women back their hormones. So now we're giving them horse hormones. Now we're giving them abortion pills. Then they gave them to them the wrong route. Your ovaries sit inside your body. Anything you take by mouth, immediately it's filtered to the liver. Liver misses it around and makes metabolites. And those metabolites can have bad properties. Well, your ovaries don't do that because they're secreted straight into the bloodstream. But these pills that they were giving to women would go into the liver and would come out horrendously, causing bad things. Blood clots, you'll get to see this, other things. But that in it, like, I will never give a woman in my office, if she says, I want to do my estrogen, I've got a girlfriend, she does hers by mouth, she takes pills. I go, well, you need to go see her doctor and let him commit malpractice on you. I won't do that because of what, it raises your risk of blood clots taking oral estrogen by 420%. Whereas doing it the transdermal route, you're going to lower your blood clot risk by at least 10%. And then the wrong women. These women were way too old to start this stuff. And when I say start this stuff, if they had started bioidentical human hormones, there would have been no age limit. But think about it. If any woman has ever been on the pill, most OBGYNs are going to stop you being on the pill by age 40, at the max 50. Why? Because your risk of a blood clot or heart attack from the pill now far exceeds your risk of getting pregnant. That goes to show you that there are so many risks with these synthetic, even real estrogen taken by mouth. Next slide. So while I'm on this one, this is to remind me, what's the other reason why you don't have your OBGYNs talking to you about it? You can't patent human hormones. Our creator made these things. You can patent the solvent that's in the estrogen patch that you or maybe some of your friends wear, but you cannot patent the estradiol, the estrogen that's in the patch. Whatever that testosterone cream that men, I don't like using it, so I can't even remember its name, but the patent is on the solvent in the gel. It's not on the testosterone. You cannot patent it. So there were no drug reps coming to the OBGYN's office bringing free lunches, but they're bringing Premarin, and they're bringing other things, and they're pushing that, and they're pushing that. And then they say things like, you know, there are no long-term studies on human hormones. I go, the history of mankind is the study that you need. Why aren't there long-term studies? Because who pays for these studies? The drug companies. Every medical journal study has been supported by money that comes from a drug company in hopes that, so they're not going to tell you about this stuff that's natural because there's nobody there to make money and, for them to make a profit. So next one. So what are bioidentical hormones? These are not similar to what your body makes. They're exactly what your body makes. Now I'm going to tell you how it's done. But if I have 2 twin sisters, one twin sister had a hysterectomy, and let's say that they're 38 again. So they're still possibly ovulated. Most of them are at 38. One sister has had a hysterectomy, total hysterectomy, and she's my patient, and I've got her on human hormones. And her other sister is not on human hormones. And we draw their labs, and my staff mixes them up. The lab cannot tell you which of these specimens came from what I'm doing with her, and which of these specimens came from what the other one's ovaries are doing to her. because they're not like each other, they are each other. How did we do it? All right, in the old days, insulin. Why am I talking about it? Because if I wanted to put somebody on insulin, I had to ask them, what do they think about pork products? Because if they're Muslim, I'm going to have to give them cow products. If they're Hindu, I'm going to have to give them pork products. If they're vegan, they're out of luck. They're going to get ketosis. Well, today, what do we have? We have what's called humulin. Where does it come from? It does not come from humans. But they took the genetic code for insulin and they spliced it into a vector. What was the vector they spliced it into? Fecal bacteria, E. coli. E. coli makes the insulin that all the people that you know that are on insulin are taking today, and it's called humulin, because the end product is exactly insulin. It has nothing to do with the bacterium. It's just the slave or the vector. So for the sex hormones, estrogen, testosterone, progesterone, they usually come from yams or soybeans, because those products or those plants have precursors that make it easier to then use the genetic code to make the end result, which is not a plant hormone. Because people have heard about phytoestrogens and soy products and stuff. That's not what I'm talking about. They just use that ability of the plant to then create the human hormone, which again goes back to what I said, is identical to what your body's making probably right now, or it did when it was not in, through middle age. Next one. So the other metaphor I like to use is you go check your tires, air's out of them, you put air in them. Did you do something weird? No, you just put exactly what leaked out back in the tire. That's what I'm trying to say. We're just putting what you used to make back in you. Go ahead, next one. So what are her hormones? Estrogen, testosterone, progesterone. Next. Benefits of estrogen. Clinically, when a woman's going through menopause, perimenopause, when she starts losing estrogen, that's when she's having the hot flashes and vaginal dryness. Medically, though, this is where it gets important. A woman's risk of osteoporosis is nil before menopause. Nil. Now think about it. You turn 40, 45, 50, you don't stop eating calcium foods. You don't develop a malabsorption syndrome, but you lose estrogen. Estrogen is what is responsible for both men and women's bone densities, to mineralized bone. You go, why estrogen? I go, I'm not the creator, but he decided that estrogen is going to make our bones stronger. Because think about it, you don't stop eating calcium and or develop so that's what happens. When your estrogen levels go down, that's when you start to get brittle bones. That's what the NIH realized. That's the woman who falls down, breaks her hip, goes to the hospital, gets pneumonia, doesn't come out. Costs the government a ton of money. Cardiac disease, coronary artery disease. Women don't have heart attacks before menopause. They might have a weird electronic or electric arrhythmia, but they don't have what we consider to be heart attacks until after menopause. Then a woman's risk is identical to a man her age. Identical. Just those two things. Every med student reads something called the Framingham study. We learned this in med school. And so you might be asking yourself, why in the heck isn't my primary care doctor taking care of this? Nobody goes to med school without learning this. Because they're all thinking back to that WIH study. Because at the end of that study, it came out with this huge paper. Big black box warnings. Hormones are horrible. Didn't bother to say horse hormones in human women are horrible. It just said hormones, and everybody remembers that. I remember that. That was when I was in school. Had we been told by our seniors, don't give those women horse hormones, that's bad. We go, duh. Didn't have to go to med school for that, did we? But that's one of the reasons they ignore your heart, because they're worried about the WHO study. Alzheimer's lowers it by 50%. Colon cancer, no idea how these things help Alzheimer's and colon cancer, but documented 50% decrease if you're on your hormones. Next slide. So progesterone. Progesterone doesn't get nearly enough attention. Well, let's go to the next slide. I think I'm going to say something. Its biggest thing is protecting the uterus. Like I said earlier, when you're pregnant, the very first thing that little egg starts to, fertilized egg starts to make is progesterone. It's protecting that egg so that it doesn't get flushed out with the period. It balances estrogen. It is your friend in perimenopause. Perimenopause, you actually lose progesterone faster than you lose estrogen. You go to a bookstore, the female section, as I call it, there are all these books on what's called estrogen dominance. Well, that's estrogen without the balance of progesterone. Stimulates new bone. Prevents clots in coronary artery disease. That's huge. Why do I say you sleep like a baby? Because if I give it to you by mouth, we do progesterone by mouth. The metabolite has affinity to GABA receptors that lead to sedation, and women will come back to me and go, Dr. Ibrahim, look, if you don't do one other thing, then what you've done for me about sleep, we're going to call this a hit because they're sleeping so well. Documented studies, we can show that their REM sleep almost doubles. A woman that sleeps better takes more steps the next day, she loses weight. So the benefits go on and on. But the biggie protects the uterus. That's what the GYNs think of. And they oftentimes think, well, if you don't have a uterus, you don't need progesterone. Well, you know what? If you leave the ovaries, which they're doing now more and more often, why? Because they now realize taking those hormones out of women is dangerous, so they leave them. The ovaries don't know that that uterus is gone. It's going to continue to make progesterone. I'm going to use another thing that some of those, and I'm good friends with OB-GYNs. The person who taught me all of this is an OB-GYN. Where was I going with this one? I can't believe I lost that train of thought. It'll come to me in a few seconds. Let's go to the next one then. So I have women that are nowhere near menopause. They might be 29 and they're just interested in more testosterone for muscle mass or whatever like that. But I'll put them on progesterone. Makes their periods lighter, fewer days, eliminates cramps. I'm the father of 2 daughters. If I could have, I would have started them on progesterone at the age of 13 in a millisecond. No PMS. I mean, I tell every woman progesterone is your best friend. But what it does to keep you from having breast cancer and blood clots is amazing. Again, every med student knows these studies. Women who have been pregnant have far less of a chance of developing breast cancer, and if they do, that cancer is going to be statistically less aggressive than a woman who's never been pregnant. Why? Because progesterone levels during pregnancy are astronomical, and it serves as a lifetime protectant. Doesn't prevent completely, but does protect for a woman from breast cancer. Next, please. Testosterone. Testosterone is not just for sex. Next slide. What it does for mental clarity is phenomenal. Well, this is in all the slides, so I'm just going to tell you. What it does for fat loss is huge. There's going to be a slide that comes up that's similar to this, but where I'm going with it is, I'll have a woman come in and she'll say, Dr. Ibrahim, look, I'm not a closet eater. I know wine's got 150 calories a glass. I'm counting that. My personal trainer used to come once a week. Now she's coming twice a week. I'm still going to the gym every other day. And then she'll stand up and she'll put her hands out beside her hips and she'll go, nothing's happening. Well, because you can't lose fat because of what's the reason? You can't run your way to thinness. That's 100 calories a mile. That's not going to happen. But a pound of muscle is going to burn about 1,500 calories a month just to stay at body temperature. And then you exercise that muscle, it's going to burn maybe 4 times more. Muscle is your fat burning machine 24 hours a day, working out and asleep, bar none. What's the recipe for muscle? Resistance training at C3. And walking is a resistance training. Number 2, protein in your diet. Sorry, vegans, eat some protein somewhere, but you got to have protein. And then last, testosterone. A woman in menopause will routinely get a lab report and it will say testosterone levels are undetectable. That woman can work out till the sun goes down how many times and she will never put on muscle mass. And then she gets frustrated and she quits going to the gym and just resigns herself to, I'm going to be fat like all my friends that are in menopause. Doesn't have to be that way. But this is what I want you to see. If you go to something called Google Scholar, Google Scholar is a search engine for academicians, scientists, doctors. You type in 2 terms, write this down, testosterone, and then morbidity, M-O-R-B-I-D-I-T-Y, I think. Morbidity just means major disease. And the screen's going to pop up, and just start looking at it. And I'm going to tell you what the gestalt, the overall thing you're going to see. It's going to say low levels of testosterone predict. Now, the study's going to be mostly in men, but this is a good one. This one was in women. But it's going to say low levels of testosterone predict higher incidence of fill in the blank, Alzheimer's, cardiac disease, depression, certain cancers, across the board. Page, next page, next page. Or you'll see things that say low levels of testosterone predict higher incidences of fill in the blank. It's life-saving for some people. Next. Body composition. So, you know, this is a big one on the female side that I get all the time. Next. You can look at a picture. Y'all can do it. I mean, and I can certainly do it. But I can look at a woman's picture over the ages and tell you, she started menopause about here and she's totally into it right here. You can just see the body fat goes up, muscle mass goes down. She doesn't have testosterone anymore. She can't put on muscle. She can't burn fat. You can look at somebody. Next. All right. I like this slide, and I'd like to hear your view on this. So they wanted to find out, what does testosterone and exercise do to muscle strength, mass, and all that. So the placebo, no effect. And we're looking at that's fat-free, increased muscle mass, and muscle strength. So no effect. All right, let's give them testosterone, but let's not exercise them. Okay? Well, we see significant improvement in all three of them. All right? Let's not give them testosterone. Let's give them a placebo. Let's exercise them. So this is exercise alone, testosterone alone. There's still a significant increase. All right. Now, I like to point out to the couch potatoes, yeah, don't be telling me that just because doing testosterone by itself gives you a greater increase than exercise by itself, because the killer is when you combine testosterone and exercise. That's way great. This is higher than the sum of each of these and all of these. In other words, if you're going to be working out and you do testosterone, you're going to get a much greater effect for what you're doing. I think if this slide doesn't say it, should be the next one. Next one. This is where I tell people, make your workout work again. So many, especially women, men still have testosterone. They just don't have much. It's gone down a lot, as you'll see. But women can get to a place where they don't have any. And again, they're working their asses off, but they're getting nowhere because they don't have the tools. Next. Time to talk about men. Andropause is male menopause. All men are gonna, go through it if they live long enough, but few will admit it. It's getting better. The younger guys grew up with Viagra commercials, so they don't have as much of an issue, seeking medical help for what, some people would call a male inadequacy. The older guys can still be, curmudgeons about it. I don't need to go in there, I'm fine. Next slide. While he's falling asleep after dinner. Can't concentrate, doesn't remember where anything is, depressed, can't sleep, getting weak, getting fat, libido, and erections. I remind every guy, look, when we were 20 and we could do it 4 times every night, Viagra hadn't been invented yet. I go, so now you're 60 or 70 and you're having problems. You know what? You're not Viagra deficient. You didn't need it when you were younger and could do it, like I said, multiple times a night because you had enough testosterone. So, yeah, I'll give men Viagra, but first time I go, let's start with what's really your problem. Your real problem is your lack of testosterone. And a point about labs. I know this is not on the slide, but a hormone lab report is so difficult to interpret because what's a great lab result or great lab report? Pregnancy. You are or you're not, right? No ambiguity, right? But then you do these hormones. Well, I'm sorry. Every woman feels different every day of a 28-day cycle and every day of a 9-month pregnancy. So when you felt good on your cycle, you might have felt miserable. And, and when you felt great in your pregnancy, you might have hated it. So what is my estrogen supposed to be? I don't know, because every woman's different. But, this lab report has to tell you something. So they'll take this 1,000 people, they'll take an average, and they'll take 2 standard deviations, which if you're a statistician, you understand that that's 95% of everybody they test. That leaves 5% to be 2.5 on the low side and 2.5 on the high side. So, if your doctor's looking for the letters H or L, low or high, you have to be below 2.5 percentile or above 97.5. No guy for sure is going to drive his car with 3 percentile of the oil in the in his oil reservoir across country. But the lab report would say you're fine. You haven't fallen below the range. So, yeah, I just always caution people who come to me. They say, "Well, my doctor told me my hormone labs were fine," and I'm saying to myself, "Well, your hormone doctor, your primary care doctor is not a hormone doctor and doesn't really know how to interpret those labs." Next, please. All men lose testosterone after their peak years of about age 22. All men. Menopause is abrupt. Men, they're losing it little by little. Think about it. And I'm going to show you the next slide. Just go ahead to the next slide. Well, let's stay here. Go back. By the age of 50, all men, and when I say the word all, that means 100% of men, are at half their peak levels. You can drive a Maserati with the tires half inflated. It's not going to perform. And so, if you drove to work with the tires fully inflated and I let half the air out and then you went someplace for lunch in your car, you might notice that. But if I had to let it out little by little over 30 years, you're not going to notice it. And you're sitting around driving your Maserati thinking you're all big and high. No, you're not. You can't possibly be performing. The next slide. So this is like the 2 standard deviation range, and this is going to be in the middle of the average. Peak age, about 22. Age of 50, this is half. Age of 60, this is 1/3. Age of 70, 1/4. 1/4. No man escapes this. Yeah, you might have some super stud athlete that's way over here, but by the time he's at this age, he's here. He's still going to be half. All men are going to be half by the age of 50, 1/3 by the age of 60, and 1/4 by the age of 75. You can't escape it. And this is, I should have said this during the menopause slide. I have all these people, I just don't get it, Dr. Ibrahim. I mean, I eat organic, or I'm a vegan, and I'm going to whatever, every day, and da-da-da. And I go, look, you can do all that fancy high living, healthy living, whatever you want to. You can't stop the clock from ticking or the calendar from turning, though. In other words, none of that is going to help. Until we learn how to control time, you're going to have to do something, either suffer through it or be on some hormones. But good living is not going to stop things from happening that are going to happen. Next. Going back to some of those studies, higher testosterone, lower mortality, pretty much every disease that they look at. Every disease they look at. Cool COVID study. I don't know why they did it, but it was a pretty cool study. In Germany, they found that men admitted to the intensive care unit, if men had higher levels of testosterone, they had half the mortality rate of men that entered the intensive care unit with lower levels. In other words, men with low levels died at twice the rate. So I would tell patients that would come see me, I go, look, testosterone is not to keep you from getting COVID, but it could easily keep you from dying from COVID. And we've got the studies. Next. So in summary, both men and women need hormones. Men, we're lucky, it's just really testosterone. Women, it's going to be all 3 of them. Even if you don't have a uterus, I still think you need progesterone to fight cancer, heart disease, and dementia. Next one. It's just the phone number. Everybody that's here tonight, if you call, you make an appointment, y'all get some kind. I don't know what my office manager does for it, because I never think about the marketing stuff, because I do the doctor stuff. I'm going to send a copy of this talk in case you've got friends that want to be here, and you send it off to them. And now's when I'm going to take questions. I do ask this one thing, though. Please don't ask me about your personal issues, or like your sister or something like that. Nor do I want to hear, well, my sister had this. I mean, I'd like for it to be something that everybody could go home with, that would help everybody. All right, anybody? Yep.
So clients that I experience male, I hear a lot of them talk about estrogen blockers for males.
Yeah.
And I don't really have an opinion of that because I don't have enough information and knowledge to know if that's a benefit or not.
Well, let's just say if I put a man, so men need some estrogen. What's wild is if I have two, let's just say 62-year-old patients, husband and wife, they're both 62, and I draw their labs, the man's estrogen levels is going to be higher than the woman's. Men make estrogen from their testosterone, but too much estrogen leads to bad stuff, heart problems and belly fat. Too little leads to lack of concentration, memory problems, bone problems. So when men talk about an estrogen blocker, it's usually the guys that are already on testosterone. Testosterone can aromatize to estrogen. That's where men get their estrogen. And so, yes, we follow men's estrogen, and if it gets, and you can block it with some supplements, but if it gets too high, you sometimes have to use a drug to block it. But most I can control with supplements. And if a man's estrogen gets too high, he completely negates his testosterone. So I'll have a guy that will show up and say, Doc, I was just seeing my primary care for my testosterone, and man, I'm telling you what, the first month or so, I felt great. But then, and I'll sometimes interrupt and go, started crying at dog food commercials. Yes! And I go, yeah. And I'm thinking, because the primary care doc didn't know to block his testosterone to estrogen conversion, and his estrogen is through the roof. And you're like, how the hell did you know? But you see, did that answer what you're looking for? Okay.
So if men are more likely to die from COVID with low testosterone, where does that leave women without testosterone?
That's a good question. They didn't study women in the study, so I don't know. And I look at that study more as an anecdotal, like, never saw that one coming. And not being an infectious disease person, I would never go out there and advocate, well, you need to have all your people on, testosterone. But it's just a cool study that I paid attention to because it used what I do.
Interesting.
I just had a question. So if someone were to come in your office, what is the process?
Okay, great question. So you come in. And let's just say, and I ask, when was your last period? And you go, 4 years ago. All right, I already know you're in menopause, but I got to get the labs. But cover up my microphone. I don't have to wait for the labs to come back to start treating if I know somebody's in menopause. I just have to have a baseline. Another thing, as I taught my daughter who's a physician, treat the patient, not the piece of paper. Labs in hormones, labs are really only important for men and for reasons that are beyond this lecture. Asking the woman what's going on. That's how I change my doses. Because like I said, you might feel great at a certain time of the period and you might hate that time, and only with your feedback can I adjust the dosing to match what works best for you. But we get labs. So we'll get labs, and then I'll run through the different options of how to give estrogen, testosterone, progesterone. Well, I'll just do it because I don't think it's going to be that long. Everything has to go through the skin except progesterone. So progesterone, I'll let you do it by pill, but if you don't want to by pill, we can do it by cream. Estrogen can be done by a cream, a patch, or what we call an implant. An implant looks like a piece of rice or a grain of rice, goes underneath the skin, does not hurt, slowly dissolves over about 3 months' time. It doesn't go poof at 3 months, but it just sort of has fallen below the therapeutic level. And so depending on what a woman's preference is, the vast majority of women are like, I don't want to be fooling around with that cream or patch. I mean, just put the pellets in. So, we'll just put the implants in. Testosterone can be done with creams or implants. There's no patches in the United States for testosterone. So progesterone's a pill. Estrogen is either going to be a cream, a patch that you change once or twice a week, or an implant. And testosterone is either going to be a cream, which is useless unless you put it in your vagina, which now that's messy and inconvenient, but at least it will get absorbed. Cream in men, it doesn't get absorbed. Creams also transfer to animals. I've had patients whose dogs grew boobies. I've had a patient who came to me because his doctor wouldn't do injections, or men can do testosterone as injections too. His doctor would only do creams, and his 4-year-old daughter was growing pubic hair. So, there is a huge transference with creams. So you would, and then I would tell you is this: we have a phenomenal messaging system, phenomenal. If you send a message through that HIPAA compliant messaging system before 4:50 p.m., it will be answered, and it will typically be answered within 10 minutes. And nobody goes to lunch if there's a question on the board, and nobody goes home if there's a question on the board. So, and that's something that people love us for, because they'll go to these other practices and they won't hear back at all, or it might be 2 weeks. And we've spoiled them because they've grown to realize, well, hell, I just sent my message. I mean, it's been 45 minutes and nobody's returned my message, because it's usually that quick. And then we'll have a visit at 1 month, which is, to be honest with you, not necessary, because we've drilled it into their head. Don't wait a month if you're having problems, but we do something in a month. And plus there's some things that we follow up on. At 2 months we get labs, just because we have to. At men it's different. There's some things that can go wrong in men from hormones that I want to catch early. In women, that doesn't happen. We adjust everything based on what you tell us, but because it's controlled, we have to get it. And then 95% of my patients choose implants on the female side, and that's a typically every 3 month setup. We have what we call a starter program for both men and women. That it's got more visits, more labs in the beginning, but what it does is it doesn't commit them to a year. Then we have the year program, which is less price if you did it by per month kind of deal, but they pay for it up front, and then it also gives them a bunch of discounts down the road. And we don't have a collection agency, so if anybody wants to fire me, they can fire me, and we just prorate what they've done and give them back their money. Men, for testosterone, there's creams that I think are useless, but then there's injections and implants. The vast majority of the men that choose injections are men that were already doing them. To be honest, men are scared. Women aren't, but men have a hard time. We teach them how to give themselves their own testosterone, and most men are too scared to give themselves their own injection.
So is it estradiol you're giving everybody?
So for women, estrogen it's estradiol, which is a great question, because this is going to lead me to something that I didn't bring a slide for. I've got what I call the world's best face cream, and it's a prescription, and in it there's hyaluronic acid at a strength 500 times what you can get at a boutique. It's got a copper peptide that's phenomenal, but it's got estriol in it. There's 3 types of estrogen that women make. Estradiol is what y'all all think about when I say the word estrogen. Estriol is what pregnant women make. And then there's something called estrone, which I'm not going to get into. So why do pregnant women have that beautiful glow of pregnancy? It's from estriol. And so I'll tell a new woman, it's like $300. It lasts about 3 months. And I'll tell a new patient, I go, now look, I call this the world's best face cream. I go, you do it, ideally twice a day, but at least once a day. It's going to be about 3 months, so it's $100 a month. If you're not thrilled with it, bring it back empty, and we will give you something in this office of value or greater if you're not thrilled. I swear to you, I will rue the day that some woman does what I'm about to say and keeps me from being able to say this story, but in 13 years, no one has ever brought it back. So people ask me, what do I do to my face? Well, I do all the stuff in my office, the laser stuff, but I put 2 products on my face, and that's one of them. So that's estriol, yeah.
But the patch.
The patch is estradiol, the pellet is estradiol, the vaginal cream is estradiol. And you remember, estrogen is clinically, hot flashes come from too little, and vaginal dryness comes from too little. And I'll tell patients, I go, look, if you like lube in the bedroom, fine. If you need lube in the bedroom, I need to know, because I need to up somebody's dose.
What's the time frame for treatments like seniors?
Oh gosh, I mean, if I put pellets in a woman, we've literally had them call from the parking lot after they've left the office. I can feel my pellets working. Now, so whether it's placebo or not, I don't really care. But I tell patients, I go, give it 2 days. If you're not feeling the love, which is the easiest way to tell about testosterone, or for women, hot flashes, vaginal dryness, If you're not seeing all that fixed by 2 weeks, by God, let me know. But typically, it's within 2 days. I mean, you'll have a woman miserable from hot flashes, and literally within hours, she's like, "Oh my God," you know, they're gone.
Is it because the pellets absorb differently than a patch, or your
No, the patch is just as fast.
Okay.
Yeah, but there's not a testosterone patch.
Right.
The testosterone cream does take longer to build up a level. You know, the pellet's right there with the blood supply. So first heartbeat,
Right.
there goes some estrogen, testosterone. Yeah. Anybody else? Thank you guys for coming out. I do appreciate it. I think our contact, my office contact information is on there. Lastly, I think I said this in the beginning. I can't remember if I did, or it might have been you I was telling. But I tell patients that are hesitant, but they sort of want to, I go, look, this is not like cutting off your thumb. If you're not happy with it, quit. I mean, it doesn't stop. You know, your body might not make as much testosterone while you're on it, but once you stop, it'll start making it back again. It doesn't make it when you're on it because they get lazy. You know, men are lazy and they just don't. You know. But if you stop doing it, no harm, no foul. Same thing with women. Stop doing it, no harm, no foul. The only reason why people stop, and it might be they can stop seeing me, but they don't stop hormones, is they don't like me personally, or we might be too expensive. And then they might go find somebody else. But I don't know anybody who ever stops the hormones once they start.
This is neither here nor there, but I feel like crying, which is probably why I should come to you, because why do I have to be 73 and have gone all these years and not have this information from, I know you can't answer this, I'm just saying.
Well, it goes back to the 2 reasons. There's no drug rep showing up in the office buying lunch, and they're bad-mouthing bioidenticals because they're saying there are no studies. And then there's the WIH that came out with hormones are horrible,
Yeah.
and didn't tell, you know, these young mush minds that didn't really know what was going on, that horse hormones and synthetic hormones are not good, and that's why.
Because all I know is estrogen is cancer.
Right. The reality, there's absolutely no increase in breast cancer from bioidentical estrogen. I didn't say it decreased, but there is no risk that's increased. Can you get breast cancer? Yeah, but you're not going to get it just because you're on estrogen. Your risk of getting it is the exact same, and they've got a ton of studies on this now, than the woman who's never done estrogen. And they've also got studies, the women that did the synthetic horse stuff have a huge incidence of breast cancer and uterine cancer. Why they didn't tell you is education and exposure. I mean, I didn't prescribe testosterone when I was a urologic oncologist, you know, because back then we thought it caused prostate cancer. Today we know it's the exact opposite. I didn't talk about that. Today we know it's literally the exact opposite. If you go to Google Scholar, you'll now see men with low levels of testosterone have higher incidences of prostate cancer. My brother, he's 18 months younger than me. I diagnosed him with prostate cancer recently. He's also a patient of mine. He went to Langone for his prostate cancer evaluation. Now, the major medical centers are starting to get this. They kept him on his testosterone. I mean, that was unheard of. It's a 180-degree change of things. For women, it's going to be like that with estrogen. I don't want to get ahead of myself, but I've seen some of the studies, and they're going to come out with just the same kind of data that prove that testosterone was not the villain with prostate cancer. They're going to show how estrogen is being over-villainized when it comes to breast cancer.
And in fairness, my internist just went through everything you just
Say what?
said. My internist just literally said everything you just
Yay,
said.
you
It said
got-
that our age has been done a great disservice by my mom's age
Yeah.
and the misinformation.
Yeah. My mom got
77
cancer.
and
My mom did hormones.
Right, she
Yeah,
said,
to go.
"I'm sad for your
She
generation."
didn't do bioidentical because if she's a little older than you by maybe 18 years, she didn't have they weren't there. You know, yeah, that's the sad
It was
part.
kind of sad to be called a generation.
Yeah.
Because my internist is like 30-something. But she's like, your generation has this terrible disservice done to them from your mother's generation. And I was like, what? well, A, I'm old, thanks. But B, this is really helpful information,
Yeah.
and she truly just,
Yeah.
just
And,
went through everything you
and
said.
my
So-
daughter is a family medicine doc. But you know, she's heard me talk for years, and like with prostate cancer, all this stuff, she's like, I wish they would let you do a lecture at school, Dad, because she goes, not only are we not being taught things, we're being actively taught wrong things. And you know, I wish I was that influential, but at least your internist knows about
Yeah,
that.
she's clinic trained. I don't know if that's where it came from or what, but she's wicked smart, and she sent me all the studies you referenced. So no, there are some that are out, but
Yeah, they're new.
it's really
They do,
fascinating
yeah.
to me because it's like, wow, my mom is like, don't do estrogen, it'll give you cancer.
Yeah.
Yeah.
It's like,
Yeah, and I'll have women who've had breast cancer that was estrogen positive receptor, ER positive, and they're going, Dr. Ibrahim, I can't find any doctor that will write for estrogen. I go, I will. I go, look, there's a minefield out there. There's 100 mines in it. 80 of those mines are coronary artery disease. 10 might be breast cancer. 10 might be other things. I go, you run through the minefield. Don't hit a coronary artery disease mine. In other words, the risk of dying from coronary artery disease is so much greater. And so these women are like, I'm miserable. I'm tired of people worrying about an effing hypothetical that might not ever happen. It might have a damn heart attack in 20 years. And I'm going to go 20 more years, miserable, hot flashes, dry, no energy, da-da-da-da-da. And they're like, and I go, all you have to do is sign the consent. I'm going to write a note saying that we talked about this in front of my medical assistant. I'm going to name her by name, and I'll go ahead and treat you. Or the woman who's had double mastectomy. She doesn't have breast tissue. Where's the cancer going to come from? I mean, if we're 5 years or more out, she doesn't have metastatic disease, there's no tissue to turn into breast cancer.
But how come it still happens?
Well, the biggest reason is it was either metastatic or it wasn't a full resection. Yeah. Thank you, guys. Don't want to keep
Thank you.
Yep.